So it's my pleasure to introduce Dr. Janice Kwon. Dr. Kwon is a gynecologic oncologist at BGH and BC Cancer and a professor in the Department of Obstetrics and Gynecology at UBC. And she serves as our surgical tumour group chair for gynecology at BC Cancer, chair of the Priority and Evaluation Committee, which is called PEC, and Research and Outcomes Evaluation Committee at BC Cancer, and co-chair of the National BRCA Collaborative. And Dr. Kwon's research focuses on hereditary cancer syndromes and health policy and gynecologic oncology, including cost-effectiveness modelling of genetic testing and risk-reducing strategies and de-escalation of treatment. And her work has influenced national guidelines on BRCA and Lynch syndrome testing and shaping cancer prevention and treatment strategies. So thank you so much, Dr. Kwon, for speaking with us today.
Thank you, Dr. Jameson, for that introduction. So I'd like to thank the GCI for the invitation to present to you today, and also to the GCI for allowing me to be part of a research enterprise that is invested in improving the treatment and outcomes for our patients with gynecologic cancers. So I just wanted to take this time to acknowledge and pay respect to the Indigenous keepers of the traditional unceded lands upon which our home and workplaces are situated, belonging to the Musqueam, Squamish, and Tsleil-Waututh peoples. My disclosures include speaker fees from AstraZeneca Canada and as a shareholder of Hexamer Therapeutics, neither of which will have any influence on the discussion today. I'm going to start with presenting an overview of ovarian cancer in Canada. Some of this will be some epidemiology and statistics, some will be some history. And then I'll go into discussion on how to prevent ovarian cancer, discuss the aftermath of ovarian cancer prevention. And then I want us to think about going beyond gynecology when it comes to ovarian cancer prevention. Now, ovarian cancer is the 7th most common cancer affecting women in Canada. As you can see in this figure, there really hasn't been much change in the incidence of ovarian cancer over the last 40 years. And despite many attempts to screen for ovarian cancer, we know that the majority of individuals will present at an advanced stage. You can see that the 5-year survival is about 44%. And the 10-year survival is only about 35%. Despite many efforts to screen for ovarian cancer, there have been a few prospective randomized trials that have compared screening using a combination of ultrasound and CA-125 versus no screening in the attempt to screen for early stages of ovarian cancer. But these screening trials have failed to find a difference associated with screening. So you can see from this trial, the UK collaborative trial on ovarian cancer and screening, the incidence of ovarian cancer is superimposed between screening and no screening. And of course, that means that the mortality is superimposed. There's no difference. Now, we know that there are certain risk factors for ovarian cancer. It is well recognized that history is a very significant risk factor. So we know that if there's a family with a number of individuals with breast and ovarian cancer, or individuals with a personal history of breast and ovarian cancer, that's a significant sign or indicative of a hereditary predisposition. And in this particular case, a BRCA mutation or pathogenic variant. Now we know that individuals who inherit a germline pathogenic variant in BRCA1 or 2 have very high lifetime risks of developing breast and ovarian cancer. So for breast cancer, that risk is about 70% for both BRCA1 and BRCA2. And the ovarian cancer risk is also high. It's about 44% for BRCA1 and between 15 and 20% for BRCA2. Now, those lifetime risks are significantly higher than what you would expect in the general population. So in the general population, the lifetime risk of developing breast cancer is about 1 in 9, or about 11%. And for ovarian cancer, it's about 1 in 70, or 1.4%. And there is no effective screening test even for these high-risk individuals. So unfortunately, screening is not really an option for these individuals. The only intervention that's been shown to decrease the incidence and mortality from ovarian cancer is risk-reducing bilateral salpingo oophorectomy, or removal of the ovaries and fallopian tubes. And for those who have a BRCA1 germline pathogenic variant, the age at which that is recommended is between 35 and 40. And for those with a BRCA2, it's between the ages of 40 and 45. Now, as you may know, Angelina Jolie went very public with her personal story about 10 years ago. She has a BRCA1 germline pathogenic variant, which she inherited from her mother. Both her mother and grandmother died of ovarian cancer in their 50s. And so she herself got tested, was found to be a carrier, and she went on to have risk-reducing mastectomy and risk-reducing bilateral salpingo oophorectomy. And so you can see her on the cover of Time magazine. This is from 2015. And then this generated the Angelina effect. There was a significant uptake in genetic testing among women in the United States as a result of this feature story. Now, not everyone who has a BRCA mutation will necessarily have a family history or know of their family history of cancer. I've always believed that the cancer patient has important lessons to teach us. Number one, perhaps that cancer patient has a family history that will inform us that she could have a hereditary predisposition. But number two, that cancer patient's tumor can tell us if she is at high risk of carrying a genetic mutation or not. So we've known for about 15 years that individuals with a high-grade serous carcinoma have about a 20 to 25% chance of carrying a germline BRCA pathogenic variant. And 15 years ago, we were the first to publish a cost-effectiveness analysis demonstrating that it's cost-effective to test those with a high-grade serous carcinoma for a BRCA mutation. This would enable family members to undergo genetic testing and undergo risk-reducing interventions to avoid the diagnosis of breast and ovarian cancer. And many jurisdictions adopted guidelines subsequently indicating that all individuals with a high-grade non-mucinous epithelial ovarian cancer should be referred for genetics assessment, irrespective of age or family history. Now, initially one might say, well, why is it important to test ovarian cancer patients for a BRCA mutation? Because the nihilistic perspective is that if they've already had cancer, then what's the point? Well, there are three compelling reasons to recommend genetic testing for ovarian cancer patients. Number one, now there is a therapeutic implication of knowing that information. There is treatment with a class of drugs called PARP inhibitors, which have been shown to improve survival in individuals who have a BRCA, a pathogenic variant. The second reason is they're still at risk for developing breast cancer, and that risk is significantly elevated if they know that they have a BRCA pathogenic variant. And finally, there are significant implications for family members if that information is known. Now, keep in mind that BRCA1 and 2 aren't the only game in town. There are a number of other genes that are associated or that are implicated in the development of ovarian cancer, including BRIP1, PALB2, BRAD51C, and D. These are called moderately penetrant genes. The risk of ovarian cancer is not as high as they are for BRCA1 and 2, but still markedly elevated over the baseline population risk. And these individuals are also advised to consider risk-reducing salpingo-oophorectomy around the age of 50 to avoid the diagnosis of ovarian cancer. And as a result, now panel-based testing is recommended in most jurisdictions instead of just BRCA1 and 2. And this panel-based testing would include all of those genes, including mismatch repair genes. Now, I am the co-chair of the National BRCA Collaborative, which is an organization with members from 6 stakeholder organizations in Canada, including representatives from medical genetics, genetic counseling, gynecologic oncology, pathology, and nursing. And Ovarian Cancer Canada is our patient partner. And at inception of this organization in 2018, our primary mandate was to optimize opportunities for genetic testing among available or eligible ovarian cancer patients. So when we first started this collaborative, this is what the genetic testing landscape was like in Canada. So prior to 2019, you can see that every province had different criteria for genetic testing among eligible ovarian cancer patients. We'll say that BC had the most inclusive testing criteria at that time. But as a result of advocacy and efforts across the country, after 2019, there was harmonization of testing criteria so that all provinces were then able to offer anyone with a personal history of non-mucinous epithelial ovarian cancer at any age to have genetic testing. So that may be well and done, but there are still significant challenges to genetic testing. Now, in the traditional model, physicians had to refer patients, ovarian cancer patients, to the genetic counselor. And then after the genetic counselor, then the patient would consent to a blood draw. And after the results were available from that blood draw, the patient would then meet with the genetic counselor again. That process could take years. And so, as you might expect, there have been low rates of genetic testing for patients with ovarian cancer. This has been described in multiple studies. So until recently, only about 1/3 of ovarian cancer patients received genetic counseling and testing. And for a while, it was the genetic counselors who seemed to be the rate limiting step. It was well recognized that there's been a shortage of genetic counselors throughout Canada and the United States, and this has been well documented. We've now adopted a new model in BC and across many jurisdictions across Canada and the United States called mainstreaming, or here in BC, it's called GenOnc. And this was to overcome that problem with the shortage of genetic counselors. So with the mainstreaming model, a referral for genetic testing is made directly from the oncologist or the physician. So the first step with the referral to the genetic counselor is bypassed. So the oncologist can give the patient a requisition for a blood test to have that genetic testing done. So that saves some time from having to be referred to the genetic counselor. And there are 3 options or 3 possibilities here. After the blood testing is done, if there's no pathogenic variant, which is going to be the majority of cases, then no further intervention is needed. The patient doesn't need to go to genetic counseling. If there is a pathogenic variant, then the patient will be referred to the genetic counselor. And if there's a variant of unknown significance, again, we would recommend referral to a genetic counselor. But these will be the minority of cases. So this improves the efficiency of the genetic testing process by not referring everyone to genetic counseling up front. But with this, the rate limiting step now becomes the oncologist. I will say that we are not the best at referring everyone for genetic counseling. So the physician now becomes the rate limiting step. There have been some strategies that have been applied to improve genetic testing for cancer patients. one of these strategies started here. So in September of 2010, a statement was added to all high-grade serous carcinoma pathology reports. And it was the pathologist who reminded us, as the clinicians, to refer these patients to the hereditary cancer program for genetic testing. And as a result of this, genetic testing rates increased from less than 20% to over 40% in a matter of just a few years. The opt-out process was implemented by our colleagues in London, Ontario. So they recommended that all patients automatically be referred for genetic testing. Patients would then be given 2 months to opt out of that genetic testing. And with this process, only 6% opted out of genetic testing. So the vast majority of patients with this approach actually went on to have genetic counseling and testing. We had a process here in BC called Genova. It was a three-year program in which we had funding for a nurse navigator to help patients through the process of genetic counseling and testing. Our goal was to increase testing rates from less than 50%, which is what they were prior to 2018, to above 80%. And patients were eligible for this if they had an invasive non-mucinous epithelial, ovarian, fallopian tube, or primary peritoneal carcinoma, or serous tubal intraepithelial carcinoma, if they had mismatch repair deficient endometrial cancer, or they had a family history that was suggestive of Lynch syndrome or BRCA. And in that 3-year period, there were 464 endometrial and ovarian cancer patients. 381 were eligible by hereditary cancer program criteria. 87% were referred to the hereditary cancer program. So this program did achieve what we had hoped for. We wanted to see a referral rate that was over 80%. Of those who were not referred, some declined referral, and for 15, there was no response. But this program demonstrated that a nurse navigator could help to optimize genetic testing rates in eligible ovarian and endometrial cancer patients. A similar program was run out of Viha on the island. In this initiative, patients who were eligible for BRCA testing were referred to a monthly seminar, which was led by a nurse practitioner. After consent was acquired, then patients would then have blood work, and then genetic testing increased with this initiative from 58% to 89%. Again, demonstrating that a central person like a nurse navigator or nurse practitioner could help optimize genetic testing for eligible cancer patients. And what about direct-to-consumer testing? You may have heard of 23andMe. You can order a kit online, pay $200, and then get genetic testing results. The problem with this is that there is the potential for false reassurance. So with 23andMe, one of the major limitations is that it tests for the 3 Ashkenazi Jewish founder mutations. So there is the potential to miss other pathogenic variants within BRCA1 or 2. And I just found out that 23andMe filed for bankruptcy on March 23rd of this year. So the question that I think is unresolved is what happens to all of the data belonging to these patients who have subscribed to this service. See what happens. This is a theme that's going to come up a few times in this presentation. Ovarian cancer prevention must transcend gynecology, because if we think about relying just on gynecologic oncologists and ovarian cancer patients, we're going to miss a lot of patients who have the potential to undergo risk-reducing surgery. So we know that there is a certain type of breast cancer that is associated with those with a BRCA mutation. So the most common breast cancer in the general population is an estrogen receptor positive breast cancer. That comprises at least 70% of all breast cancers. There is a phenotype of breast cancer called triple negative breast cancer. Estrogen receptor negative, progesterone receptor negative, HER2 negative, which is very rare in the general population, but much more common in those who have a BRCA mutation. So if you take 100 women with a BRCA1 pathogenic variant who have breast cancer, about 60 of them will have a triple negative breast cancer. Or if you look at it the other way, you take 100 individuals with a triple negative breast cancer. If they're under the age of 50, about 25 of them will have a BRCA mutation. If you restrict it to individuals under the age of 40, then about 25% will have a BRCA mutation. So we were the first to publish a cost effectiveness analysis looking at BRCA mutation testing in patients with triple negative breast cancers and found that it was cost effective. And again, many guidelines have incorporated triple negative breast cancer as an indication for genetic testing, irrespective of family history, age, or ethnicity. And for us, the primary motivation for these individuals to be tested when they have breast cancer is to identify those who have a mutation or a pathogenic variant so that they can undergo risk-reducing surgery to avoid ovarian cancer. But unfortunately, in our population, there are a number of individuals who have had both breast and ovarian BRCA-associated cancers. Well, what can we learn from patients with metachronous BRCA cancers? One of our UBC medical students who's here in the room today and just been matched to the OBGYN program at UBC starting in July, Ella Barrett-Chan, has been leading this study to look at the outcomes of patients with metachronous breast and ovarian cancer, BRCA associated. So there were two sources of data. First was the BC Cancer Pharmacy database. And so she looked at the data set or the cohort of 194 individuals who were prescribed olaparib for high-grade serous carcinoma. So they had to have had a BRCA mutation because we can't prescribe olaparib to patients unless they have a BRCA mutation. So then she looked at how many patients went on to develop breast cancer afterwards by searching the BC Cancer Pharmacy database for breast cancer protocols that were prescribed after. And there were 3 patients who developed breast cancer after BRCA-associated ovarian cancer. But then there were 17 who were diagnosed with breast cancer who were treated for breast cancer before they developed ovarian cancer. So this means 17 patients who shouldn't have had ovarian cancer because they have a BRCA mutation. This was a cancer, the high-grade serous carcinoma is a cancer that could have been or should have been prevented in those 17 patients. There are a couple of notable findings in this study. The average of, first of all, only about 50% of patients with breast cancer went on to have risk-reducing salpingo oophorectomy. There's certainly room for improvement for genetic testing and subsequent risk-reducing interventions. The second source of data was from the high-risk clinic in collaboration with Dr. Rona Kafitz, who's the medical director of the high-risk clinic at the Hereditary Cancer Program. So as you may know, the high-risk clinic at the Hereditary Cancer Program has over 2,000 patients referred from all over the province with a hereditary predisposition to cancer. From that high-risk clinic, there were 336 breast cancer patients, of whom 10 went on to develop ovarian cancer, and 50 who had ovarian cancer who subsequently developed breast cancer. What's interesting is that the average age at which risk-reducing salpingo oophorectomy took place in those who actually did have that procedure done was 58, which is way beyond the recommended age threshold for when that surgery should be done. So We think that there are opportunities for improvement and education amongst patients and healthcare providers about the need for genetic testing and risk-reducing interventions. Now, among those who had a triple-negative breast cancer, remember, those patients are now all eligible for BRCA testing. It was actually the minority of individuals with a triple-negative breast cancer who had genetic testing. So that's prompted a study with our breast medical oncology colleagues. So this was a paper that was presented at ASCO last year. They reported a very detailed report of treatment and outcomes of 2,339 patients with early stage triple negative breast cancer. A lot of details about staging, treatment, outcomes, but there were no data collected on whether these patients had genetic testing. So that is our next project. Of those 2,339 triple negative breast cancer patients, we want to know how many of them underwent BRCA testing. And amongst those who underwent BRCA testing, how many have a pathogenic variant? Of those who have a pathogenic variant, how many go on to have risk-reducing bilateral salpingo-oophorectomy? And our hypothesis is that there is room for improvement for both genetic testing and risk-reducing surgery. Now, where does tumor testing fit into all of this? Well, there was a landmark trial called SOLO-1 that was first published in 2018 that looked at a class of drugs called PARP inhibitors, specifically olaparib. And this study looked at patients with advanced stage epithelial ovarian cancer randomized to olaparib versus placebo after completion of first-line treatment. And this study found a significant improvement in overall survival associated with the PARP inhibitor olaparib. So you can see at 60 months or 5 years, overall survival associated with olaparib was 73%. And at 84 months or 7 years, that overall survival was 67%. So if you think back 20 minutes ago when I presented that slide on the 5-year survival of ovarian cancer in the general population, it was only 44%. So you can see this is a massive improvement in outcomes for these advanced ovarian cancer patients. Now, it's important to recognize that the patients who were prescribed olaparib included those who had a germline as well as a somatic BRCA pathogenic variant. So it could be inherited or it could be something that was acquired. And so that's where tumor testing comes in. There was a study that was recently conducted here in BC in which we did parallel germline and somatic testing in patients with high-grade serous carcinoma. Of 101 cases, there was one that had failed testing, yielding 100 tumor tests. There were 28 pathogenic variants identified in the tumor testing, including these pathogenic variants. And with the 100 germline or parallel germline tests done, the same 28 pathogenic variants were identified. And so what this means is that all inherited mutations or pathogenic variants were identified by tumor testing, yielding 100% sensitivity. And so this was published 4 years ago. So what does this mean for us? Does it mean that we start with germline testing and then proceed with tumor testing for those who don't have a pathogenic variant, or should it be the other way around? So if we take 100 patients with ovarian cancer and all 100 of them undergo genetic testing, we'll find approximately 20 who have a germline mutation and 80 who are non-carriers. Those 80 who are non-carriers would then undergo tumor testing to find the 5 additional patients with a somatic mutation only in the tumor who would be eligible to receive treatment with a PARP inhibitor. On the other hand, if we start with tumor testing, we expect that 75 of them will not have any abnormality in the tumor. 25 will be abnormal. Those 25 then undergo genetic testing to find the 20 who have a germline pathogenic variant versus 5 who have a somatic variant. So the first strategy, where genetic testing starts first, is what's recommended by ASCO. The second strategy is something that we modeled in a cost-effectiveness analysis. And assuming that the sensitivity of tumor testing is very high for detecting germline variants, we predict that the tumor testing first approach is a cost-effective strategy. Mary Claire King is an American geneticist who has this very famous quotation, and I'm sure you've heard this before: to identify a woman as a carrier only after she develops cancer is a failure of cancer prevention. Well, that may be true, but we're not going to identify all carriers, especially if they don't have a family history or they haven't had a cancer themselves. So that raises this question: what if we tested everyone for a BRCA mutation, irrespective of family history, age, ethnicity, personal history of cancer? Well, we modeled a cost-effectiveness analysis of BRCA testing for everyone in the population. And in this analysis, we predict that if we test everyone for a BRCA mutation, that will lead to a lower number of breast cancer cases, lower number of ovarian cancer cases, lower number of breast cancer deaths and ovarian cancer deaths compared to genetic testing or BRCA testing based on family history. Now, the caveat is that when we test everyone and those who are found to have a pathogenic variant undergo risk-reducing surgery at a young age, some of those patients are expected to die as a result of premature coronary artery disease or osteoporotic fractures, but that number is far outweighed by the number of lives saved as a result of testing everyone. But we know, again, that the cancer prevention journey is not always easy. It may be easy enough for us to recommend that those with a pathogenic variant undergo risk-reducing surgery at a young age, because we know that that will prevent ovarian cancer and it will prevent breast cancer in some patients. But there are a number of adverse effects from early risk-reducing bilateral salpingo oophorectomy and possibly reduced life expectancy, especially from osteoporotic fractures or coronary artery disease. Now, many of those adverse effects can be mitigated by hormone replacement therapy. But we know that hormone replacement therapy use is very low after premature surgical menopause. This was a population-based study that looked at PharmaNet data linked with population-based data on oophorectomy under the age of 50. And this study found that the rate of prescriptions of hormone replacement therapy after premature surgical menopause was only about 50%, or like flipping a coin. And the adverse effects of early risk-reducing salpingo oophorectomy or early menopause from risk-reducing surgery have been well documented. There are significant bone or osteoporotic effects, as well as coronary artery disease. So in order to, we obviously still want to recommend risk-reducing bilateral salpingo oophorectomy, but in order to mitigate the aftermath, I like to think of front-end mitigation and back-end mitigation. So let's start with back-end mitigation. This means dealing with the adverse effects after the intervention is done. So recognizing that a lot of women are reluctant to take hormone replacement therapy after risk-reducing surgery, we developed this Gynecologic Oncology Survivorship Clinic. This happened in February of 2021, so it's been just over 4 years now. And the goal of this clinic was to provide tailored advice and recommendations regarding hormone replacement therapy to individuals with a hereditary predisposition. And so this clinic is now led by our colleague Lisa Dawson. And since its inception in 2021, we have over 500 patients who've been recruited to this clinic. So that's back-end mitigation. What about front-end mitigation, preventing menopause altogether? Well, we were, again, the first to publish a cost-effectiveness analysis predicting that a two-stage strategy would actually be effective and cost-effective for these high-risk individuals. So in this publication, which was from 2013, we predicted that if these individuals underwent prophylactic or risk-reducing self-injectomy at an early age, because we recognize that most of the high-grade serous carcinomas originate in the fallopian tube, so it made sense to remove the organ at risk, at greatest risk first. But we also felt that it was important to remove the ovaries at some point because some BRCA-associated cancers do arise primarily in the ovary, and there is still a sense that there could be risk reduction against some breast cancers in those who undergo oophorectomy. So what the figure shows is that the earlier the self-injectomy is done, the later the oophorectomy could be scheduled or delayed in order to achieve the same outcome as bilateral salpingo-oophorectomy at the age of 40. Now, these results were essentially recapitulated by our colleagues in the Netherlands. They also did a modeling study and found that, or estimated that if bilateral self-injectomy was done, say, at the age of 33, and oophorectomy was delayed to the age of 43, this was comparable to having a bilateral salpingo-oophorectomy at the age of 38. Or if the bilateral self-injectomy was done at age 40 and the oophorectomy was done at age 48, this was the same as offering BSO at the age of 43. So as a result of these analyses, this provided the rationale for the TUBA study. So TUBA is tubectomy with delayed oophorectomy. And in this study, patients are allowed to choose their intervention. They could choose to have standard risk-reducing salpingo-oophorectomy, or they could choose to have early self-injectomy followed by delayed oophorectomy. And as expected, the majority of patients chose to have the two-stage surgical procedure. Now, in this initial publication, what the authors demonstrated was that sexual functioning and sexual distress in patients who underwent the standard risk-reducing salpingo-oophorectomy was inferior, or it was worse compared to those who had the two-stage procedure. What they also found was that while hormone replacement therapy improves outcomes for those undergoing bilateral salpingo-oophorectomy, their quality of life is still not the same as those who have ovarian preservation. So I know this is a little bit hard to read, but you have a chance to look at this publication. What you see on the right-hand side are a number of menopausal symptoms. And for all of those menopausal symptoms, such as hot flashes, night sweats, difficulty sleeping, even with the use of hormone replacement therapy, their quality of life is not the same as those who have their ovaries left in situ. There was a similar study run out of the MD Anderson called the WISP trial. And in this trial, patients, again, were allowed to choose between standard risk-reducing salpingo-oophorectomy versus interval self-injectomy and delayed oophorectomy. And as expected, those who had the two-stage procedure had better physical quality of life. Those who underwent standard risk-reducing salpingo-oophorectomy had more decision regret and more menopausal symptoms, including weight gain. Now, the two groups have combined forces to what's called the TUBA-WISP-2 trial. And the primary outcome in this study is now to look at the incidence of cancer. And so the objective is to accrue 3,000 patients worldwide. We've just started accruing patients to the study. We're the only Canadian center, although it looks like we're Nunavut there. But they've now managed to accrue about 2,100 patients out of the expected 3,000. The other important trial, which we're also participating in is called ROEC, and this is a study that's being run out of Energy Oncology in the United States. This is only available to those with a BRCA1 germline pathogenic variant between the ages of 35 and 50, whereas tuba-wisp includes all of those other moderately penetrant genes and BRCA2. But ROEC, again, allows patients to choose between the two-stage surgical procedure versus standard salpingo oophorectomy. And Max is our research associate who's been running this trial. I think we've accrued over 20 patients in less than a year. So this study is accruing very well. Patients are very motivated to participate in this trial. And there's a similar study that's being run out of the UK by our colleague Ranjit Manchanda called the Protector trial. And patients have the option, again, of choosing between standard surgery, self-injectomy and delayed oophorectomy, or no intervention. And we do know that there are a number of patients who don't want to have surgery at all. Just a couple of slides about STIC. As we know, this is the obligate precursor to high-grade serous carcinoma, and the diagnosis of STIC is an indication for genetic testing. But not all STICs occur in patients with BRCA mutations. We do know that there are STICs that occur in the general population, and Kim Stewart is one of our gynecologic oncology colleagues who looked at STICs in the general population. So from the VGH database of over 25,000 self-injectable specimens, there were 196 STIC diagnoses. We excluded the majority of them because they were associated with a concurrent high-grade serous carcinoma. There were 29 isolated STICs. 9 were known to have germline pathogenic variants, leaving 20 at average risk who were having surgery for other indications. So of those 20 who were deemed average risk, they were offered genetic testing. The majority of them went ahead with genetic testing, and the minority of them actually had a BRCA pathogenic variant. But you can see that whether they had a BRCA pathogenic variant or not, the diagnosis of STIC still puts them at risk for developing a high-grade serous carcinoma. And so there's still a lot we need to learn about what it is about STIC that leads to the development of high-grade serous carcinoma when it has been removed and they've undergone a surgical staging procedure and there's no evidence of any disease. Now, ovarian cancer prevention has to go beyond hereditary because we know that the vast majority of ovarian cancers are sporadic and they have nothing to do with a hereditary predisposition. And so here's where risk reduction goes beyond high risk. Many of you know that BC launched an educational campaign in the fall of 2010, recommending that women and their healthcare providers consider opportunistic self-injectomy or removal of the fallopian tubes whenever the opportunity arose, such as instead of a tubal ligation or with hysterectomy for benign disease. And there was significant media attention with this campaign. And Jillian Hanley has really been leading the research program in opportunistic self-injectomy. A year after the campaign, there was a significant increase in the uptake of this procedure in lieu of tubal ligation or with hysterectomy. And that uptake continued to increase through to 2016. But you can see that the area with the greatest uptake was British Columbia, the mothership of opportunistic self-injectomy. And there's still work that needs to be done to increase the rate of this procedure in other jurisdictions across Canada. The most important question is whether opportunistic self-injecting is actually going to reduce the incidence of ovarian cancer. And there is an early signal that opportunistic self-injectomy appears to reduce the incidence of epithelial ovarian cancer, specifically serous cancer. There were no serous cancers identified in those who had undergone opportunistic self-injectomy. And just to confirm that these patients are comparable in terms of cancer risk. You can see that breast cancer risk and colorectal cancer risks are the same in both groups. So to wrap this up, the take-home messages are, we need to maximize BRCA testing in cancer patients, not just ovarian cancer patients, but I think there's a need to optimize or improve BRCA testing in breast cancer patients. I think we need to expand BRCA testing to the general population, because if we restrict it to just those who have a cancer diagnosis or those who have a family history, we're going to miss a number of patients. So BRCA testing for the general population is something that I think we should be investing in. We want to mitigate the aftermath of ovarian cancer prevention. We can do that on the front end or the back end with a survivorship clinic, or we can offer surgery that is less likely to reduce quality of life, and that's with a two-stage surgical procedure. And again, ovarian cancer prevention must transcend gynecology. We have to engage our colleagues in general surgery, maybe even hepatobiliary surgery, or any surgery where there's access to the fallopian tubes, any intraperitoneal surgery. And I think by doing this, we can, we'll have many more opportunities to prevent ovarian cancer and save lives. So I think with that, I'll end. Thank you very much for your attention, and I'm happy to take any questions.